We describe the influenza life cycle and distinguish between influenza and other respiratory infections. We designed a therapeutic regimen for acute influenza and listed the likely causative pathogens for rhinosinusitis and pharyngitis. And given a patient with acute bacterial rhinosinusitis, we recommended an appropriate therapeutic regimen. Now, given a patient with acute streptococcal pharyngitis, let's recommend an appropriate therapeutic regimen. These are the recommendations from the 2012 IDSA guidelines specifically for Group A streptococcal pharyngitis. So Group A streptococcus is Streptococcus pyogenes. So GAS is short for Group A streptococcal. So they do recommend that patients for Group A strep pharyngitis to be treated with antibiotics, and the duration is typically for 10 days. And they're recommending that based on narrow spectrum of activity in frequency of adverse reactions and affordability, to either penicillin or amoxicillin as the drug of choice in patients who do not have penicillin allergy to it. If someone does have penicillin allergy but it's not anaphylactic reaction, you can use a different class of beta-lactam, so first generation cephalosporin. So first generation cephalosporin are also narrow, they're well tolerated, and they are affordable. So something like cephalexin would be useful. Or if someone had anaphylactic reaction, then you gotta use a non-beta-lactam. So either clindamycin or azithromycin would be recommended. So either macrolide or clindamycin as an alternative if someone has anaphylaxis to beta-lactam. There are also adjunctive therapies that you can do. So mostly, since these patients typically have fever, you can give them something for fever that would make the patient comfortable. So acetaminophen or an NSAID. And it's important to note that they do not recommend corticosteroids in patients with Group A strep pharyngitis. For the duration of therapy of acute bacterial rhinosinusitis, the drug of choice is high-dose amoxicillin clavulanate. So that would be 2 grams of amoxicillin along with 125 milligram of clavulanate given twice a day, and this is typically for 5 to 7 days. And of course, amoxicillin clavulanate high dose is actually available as an extended release, and because the pill gets really large, so you can see here the size, it would actually be about 22 to 23 millimeters in length. This is a large pill, so they actually had to split it into 2 pills. So each pill includes 1,000 milligram of amoxicillin and 62.5 milligram of clavulanic acid. So 2 pills together will make up the high dose amoxicillin clavulanate, which would be 2,000 milligrams of amoxicillin. Alternatively, if the patient cannot tolerate amoxicillin clavulanate, so for example penicillin allergy, regardless of what the reaction was, the alternative would be doxycycline. So that would be for 5 to 7 days. In fact, all recommendations are for 5 to 7 days. And then if really there is no other choice, then we can use respiratory fluoroquinolones such as levofloxacin and moxifloxacin. And these are once a day dosing for 5 to 7 days. And of course, if the reaction was anaphylaxis, we'll do the same thing. So doxycycline, if the patient can tolerate it, if there is no other choice because of the black box warning, then the fluoroquinolone would be last option. Now, for the duration of therapy of acute streptococcal pharyngitis, you can choose between penicillin. So penicillin would be the narrowest option. Unfortunately, adherence could be an issue with oral penicillin because it's typically given 4 times a day with the lower dose, or you can do a higher 500 milligram dose and give it twice a day to improve adherence, and this will be for 10 days. Alternatively, amoxicillin is an option. So even if you give a high dose of 1000 milligram, you can get away with once a day dosing to even further improve adherence, or you can do the lower dose of 500 milligram twice a day, and this will also be for 10 days. And then of course, if you really want to do 1 dose and be done with it, you can do the intramuscular injection of penicillin G at the 1 million units. And of course, this would be obviously painful. So a lot of patients might not want to do this. And this is, more realistic for people who have adherence issues. Now, if someone has a penicillin allergy, which the reaction is non-anaphylaxis, we can use first generation cephalosporin like cephalexin for 10 days, or we can use cefadroxil once a day for 10 days. Now, if the reaction is anaphylaxis, then it's not a good idea to use cephalosporins. In that case, we have to use non-beta lactams. So oral clindamycin would be an option for 10 days. Alternatively, also clarithromycin for 10 days, or azithromycin for 5 days would actually improve adherence because this is the shorter duration. This concludes this presentation.